Welcome to this week's edition of Good Books Radio. Audiobooks.com is the chief underwriter for Good Books Radio, which is produced by UTRGV Media Services for Rio Grande Valley Public Radio. And now, here's your host, Dr. John Cook.
Welcome once again to another edition of Good Books Radio. I'm your host this week, Dr. John Cook, and with me today is Dr. J. Cohn, M.D., a professor of medicine at the University of Minnesota Medical School and director of the Rasmussen Center for Cardiovascular Disease Prevention. He was director of the university's Cardiovascular Division from 1974 to 1996. He is widely recognized for his contributions to the understanding and management of hypertension, coronary artery disease, myocardial infarction, and heart failure. He's the author of a scientific memoir, Saving Sam, Drugs, Race, and Discovering the Secrets of Heart Disease. He has published over 750 scientific papers and has been honored for his research accomplishments by the American Heart Association, American College of Cardiology, American College of Physicians, American Society of Hypertension, Heart Failure Society of America, American Association of the Advancement of Science, Cornell University, and the University of Minnesota. He has served as president of 4 national and international societies and is co-editor of a major textbook, Cardiovascular Medicine. He holds a number of patents and devices on drugs used to diagnose and treat cardiovascular disease, and that impressive resume is part of this author's book, Cardiovascular Health, How Conventional Wisdom is Failing Us. Dr. Cohn, welcome to the program.
Well, thank you, John. It's a pleasure to join you.
I had said offline that I'm really glad to have this because I'm at that age where we have to be more aware, and this book is very well written, very clearly written, and made me more aware, made me think more about the stuff that's going to happen to me. One of the things that you observe in the book is that we're all going to, at some point, have our arteries start to harden and our hearts start to get weak. But the goal of your clinic is to keep us from having what we call a morbid event until age 100.
That's the goal, yes.
Mm-hmm.
It is certainly true that as we age, all of our organs age, including especially the arteries that supply every organ in your body and the heart, which of course pumps the blood. And these will age, and some organ is going to give out, and you are not going to live much past 100. I'd love it if we could live to 200, but that's not going to happen. So the idea is to slow this natural aging process, and when it is accelerated, as it is in some people, we can identify it early and initiate therapy that will slow progression. And our goal is to identify this early disease at a proper point in which we can slow progression and keep people healthy until they reach age 100. That's our long-term goal.
Mm-hmm. The subtitle, How Conventional Wisdom is Failing Us, is one thing I want to emphasize, because you're really good. In each chapter, you talk about conventional wisdom at the beginning, and at the end, some conclusions we might draw from thinking about these things in a different way. And I want to start with medicine by the numbers. Hypertension is measured by numbers, cholesterol is measured by numbers, blood sugar is measured by numbers, and sometimes we seem to be managing numbers.
Yes, that in fact is what has happened to medicine. It's become a numbers game, and we have guidelines which are all based on numbers, what you treat. And of course it isn't the number we're treating, it's the disease process that we're trying to identify and intervene to slow its progression. And numbers may play a role in that, but when your blood pressure is 138 over 88, and you say hypertension starts at 140 over 90, it's a mistake to think that 138 over 88 is normal and 142 over 92 is abnormal. That's a numbers game, and of course these numbers are not that stable. They bounce around. Mm-hmm. So you have to really get beyond the numbers and understand the disease process.
Where do you come down on, is hypertension a marker or is it a disease?
Well, it's not really a disease. The disease is in the artery wall. The blood pressure number may be a manifestation of that disease, but it's a very unreliable guide to the presence of the disease. So we try to look at the artery itself, which is the site of the disease and is the cause of heart attacks and strokes. not look at the number alone, which can be very misleading.
Mm-hmm. And the same might be said about diabetes. Is a 126 blood sugar count diabetes and a 125 not? And, it's the same kind of question, I guess.
It is the same question, and it, of course, have led the experts in these individual areas to devise a term called pre-diabetes and pre-hypertension, to point out that even though your number may not be above that threshold, you may have the disease process. And of course, you may. It is true that people with a blood sugar of 100 are less likely to have the disease process called diabetes than those with a blood sugar of 130. But some people at 100 actually have the same disease process. The number just hasn't reached 126 yet, so you can't call it diabetes, and that's where the experts have said, well, let's call that pre-diabetes, and it's a nice way out, but it doesn't give the doctor any sense of what to do. Nobody says you should treat pre-diabetes or pre-hypertension, but if they have the disease, we would like to treat it.
Mm-hmm. Let's talk about the disease of the arteries, which is one of the culprits for progressive heart disease. And whether you call it arteriosclerosis or atherosclerosis or atherothrombosis, what are the differences there? What goes on there?
Well, there are some subtle differences. As the artery ages, it gets stiffer and the wall thickens. And that is a process that we might like to call arteriosclerosis. It also is a process that leads to plaque formation in the inner lining of the artery that can lead to clots and lead to heart attacks and strokes. And that's a process we often call atherosclerosis. Both of these processes coexist with different severity in individual people. Some have predominantly arteriosclerosis, and some have predominantly atherosclerosis. And the management strategies are somewhat different between the two, but they both are manifestations of this aging process. And if we can identify them, we have therapy which can effectively slow its progression. And that's what we're trying to do, identify the early phase of disease long before people get sick, long before necessarily their blood pressure gets high or their blood sugar gets high. Find the early disease in the artery, treat people to slow its progression, and keep them healthy until age 100.
Mm-hmm. Now, one of the things I remember I did not know when you mentioned the blood pressure medicines is that some of them actually slow the progress of the hardening of the arteries. Is that right?
Well, that's in fact what these drugs do, and that's the difference between treating a number and treating the artery. It is true that a group of drugs like ACE inhibitors, which is a very powerful medication, they're generic, they should be very inexpensive. There are some side effects, of course, like with all drugs. None of them are entirely free of side effects. But the ACE inhibitors have a very beneficial effect on the health of the arteries. They slow the aging process. Should everyone in the world be taking an ACE inhibitor? Well, no. We'd like to be selective. Give them to the people who have an accelerated aging process. Don't impose them on people who are healthy and aren't in need of slowing of the disease process. So maybe it's a third of a population that should be on an ACE inhibitor. Well, which third? Well, that's where you have to really evaluate the health of the arteries in individual patients and identify those who need to be on drugs such as ACE inhibitors. And that's just one example of a group of drugs that we often use in this population.
Mm-hmm. Let's talk about cholesterol a little bit, because there's mixed understanding about some of this, and statins do a very good job of lowering the bad cholesterol, and plaques can't form if you don't have too much LDL. But what else do we need to know about cholesterol?
Well, I think the misunderstanding is that the number, once again, is the key factor. So most people, if they go to their primary care practitioner and want to be assessed for their risk, the doctor will measure cholesterol level in their blood and will say, oh, yours is normal and you're fine. oh, yours is high and we should treat it. But that isn't really the major determinant of the disease in the artery wall. Actually, among people who have heart attacks, the cholesterol level is no higher than in people who don't have heart attacks. So cholesterol level is not the key factor. It's the fact that the cholesterol is getting into the wall of your artery, and that we can determine by testing. And those people who have normal cholesterol levels by their doctor's standards are as likely to have cholesterol build up in their artery wall than those people with a high cholesterol. So we aren't treating the cholesterol, we're treating the blood vessel. That's the secret.
Mm-hmm. We want to mention a risk factor that's becoming more and more of a problem in America today, and that is obesity.
Yes, obesity is viewed as a very powerful risk factor, and it is a risk factor, but there are many obese people who have healthy arteries, and there are a lot of obese people who have sick arteries, and the same thing is true of people who are thin. So although there may be on a population basis a higher incidence of artery disease in the obese, it's only a modest increase. The disease process is accelerated in obesity, and we're not sure if it's because of the obesity or because of the inheritance of a factor which leads to obesity but also may lead to artery disease. So all the efforts to control artery disease by losing weight have not been very impressive. It's been difficult to document that you can slow disease progression by getting people to lose weight. Maybe it's because people aren't very good at losing weight, or maybe it's because they've inherited this factor which includes weight gain, but the weight gain is not the cause necessarily of the obesity. It's the genetic factor which leads them to weight gain as well as to artery disease. We don't know that, but at this point in time, we're very adamant about people not getting obese and living a healthy lifestyle and eating properly and exercising properly. Those are good things, and they improve not only the health, perhaps, of the arteries, but the quality of life of an individual. So, yes, indeed, it's very important to exercise good health habits. But the fact is that the magnitude of health habits on disease progression is really quite modest.
Well, then let's address a sister disease of obesity, type 2 diabetes, which is on the increase in this country. You mentioned something here that I wasn't aware of, and that is the endothelial function and the secretion of nitric oxide. How does that figure into this picture?
Well, nitric oxide is a substance released from the inner lining of your artery wall, and it is a powerful protector of the artery wall. It protects the artery from cholesterol getting in. It protects the artery from a thickening of the wall and the process called arteriosclerosis. This nitric oxide secretion begins to wane as we get older, so that as we age, the amount of nitric oxide protecting our artery wall lessens, and we are at greater risk for this process of aging. Can we enhance nitric oxide? Well, there have been many attempts to do that, and there are still efforts ongoing to find drugs and food additives that might enhance nitric oxide activity. It is an exceedingly difficult process because nitric oxide is a gas. It's hard to measure it, and therefore there's no simple way to assess an individual's nitric oxide level in the body. But there is now a general consensus that nitric oxide, which we call endothelial function, that an abnormality of endothelial function contributes to the progression of artery wall disease, And that may be what we're defining when we identify the early disease in some people and not in others. We may find that it is really a deficiency of nitric oxide which leads to the disease process.
There's not a lot of definitive studies, but several people, and you discuss it a little bit, the amino acid arginine is given some credit for generating nitric oxide, right?
That's true. Arginine is the precursor of nitric oxide. That is, it's an amino acid which, in fact, does generate nitric oxide. Now, it used to be a feeling that we had so much arginine in our body that it wouldn't make any difference if you got extra arginine, because the nitric oxide deficiency is not related to a deficiency of arginine. But there's been more information gathering in recent years to suggest the possibility that arginine deficiency is a factor in the deficient production of nitric oxide, and therefore some health food advocates recommend taking arginine in excess. Well, you have to take a lot of it, and there are some side effects, and we don't really know whether it does any good, but there is certainly reason to be suspicious that excess arginine might help in some instances, yet to be proved.
Mm-hmm. You touch on inflammation, and that's something I keep seeing more and more about as I read articles on health and wellness. What can we do about inflammatory diseases and inflammation in the body?
Well, it's a fascinating question, John, and obviously you're very insightful about these things to ask that question. Atherosclerosis is an inflammatory process. The process of the plaque formation in the wall of the artery is driven by inflammation. So there have been thoughts that maybe if we could control the inflammation, it would slow the progression of the artery wall disease. A number of studies have been carried out with some of the standard anti-inflammatory drugs that are given for pain relief and arthritis, etc. These are anti-inflammatories. The ibuprofen-like drugs are anti-inflammatory. There have been efforts to document that these anti-inflammatory drugs might slow the progression of atherosclerosis. But all the efforts so far to have done that have failed to document that you can benefit the process by the standard anti-inflammatory drugs. There's been some recent studies with some newer anti-inflammatory drugs that have been encouraging, so I think you haven't heard the last of the potential role of anti-inflammatory drugs. But it is true that people who have chronic inflammatory processes like rheumatoid arthritis have a higher risk of heart disease than people without that inflammatory process. So inflammation seems to play a role, and yet we don't have documentation that attacking that inflammation will produce a beneficial effect on heart disease.
Those inconclusive studies, a lot of vitamin and supplement people harp on fighting inflammation with turmeric or curcumin and antioxidants and so on.
Well, it's driving a lot of the health food industry, and it may be right. And of course, there have been very few studies done. Doing a study, I think your listenership should be aware of how much it costs to do a very good trial with an agent to determine whether you can slow progression of cardiovascular disease. You need thousands of people carefully studied with double-blind, placebo-controlled studies of a drug versus placebo in order to document this. It's very expensive, and no sponsor is going to undertake that unless there was a lucrative potential at the end of the road. And of course, many of these health foods are very inexpensive. There's no patent protection. There's no motivation for a sponsor to carry out a mega million-dollar trial in order to document the benefits. So we don't see studies of these interventions, and we'll probably never get answers to whether these things work or don't work.
You know, it's interesting you mentioned money. I was taken by a sentence in Chapter 11, Statistics versus Biology, and I really did not expect a medical doctor to say this, but what you said is doctors have gradually and largely become subservient to the system, a system of healthcare organized not only to standardize care, but to generate maximum possible revenue with the minimum time spent on patient care. And of course, this shift was a consequence of the change in medical funding from an unstated contract between patient and provider to a more complex contract between provider's organization and the patient's insurance carrier. So
Yes.
That's a big deal, isn't it?
It is a big deal, and it's painful to me to watch this process unfolding, but it's been mandated by the financial system that time and money become a driver of the system.
You talk about early detection and how important that is. And here's another area where I often get suspicious. The idea of drug therapy to slow progression is an anathema to many. Perhaps they think the recommendation to preventive drug therapy is a subversive plot by the pharmaceutical industry to sell more pills. I have thought that from time to time.
Yeah, well, I mean, there's no question the pharmaceutical industry wants to sell pills, so their motivation is financial, but the fact of the matter is that what they're often marketing is very valuable and should be widely utilized. Unfortunately, a lot of the real potent advertising is focused on patented medications, which probably are not that important. The drugs that we advocate for are all generic. They've been around a long time. They aren't going to break the bank, and the drug companies aren't really pushing them because they don't make much money any longer on ACE inhibitors and statin drugs. Those drugs have become cheap. So there is a mixed motivation in this whole messaging, and I think the public is right to be skeptical of drug companies pushing agents which are very expensive, but they should not spread that discomfort to the kind of pills that we're recommending, which are effective in slowing disease progression and don't cost much.
Mm-hmm. Do you have concerns about the side effects of some of those that are maybe harmful to the liver and kidneys and that sort of thing?
Well, of course. All drugs, anytime you take a drug, you run the risk of a side effect. And no drug is completely free of side effects, some more risky than others. And we individualize, and that's why I don't believe that statin drugs should be put in the drinking water, as do some people. Think that it should just be added to everybody's diet. Take a statin drug because they're so effective in preventing heart attacks and strokes. Well, I think it would be a disaster if we gave statin drugs to everybody without oversight, without medical oversight. So I think we should be selective and give these drugs to people who need them and not to people who don't, because they are not benign. Yet I think that there is a general sense in the public that these drugs are so dangerous we shouldn't take them. Well, you've got to balance the benefit versus the risk. There's always a little risk, but if the alternative is a heart attack at age 50, and if a statin drug will keep you healthy until age 90, I think it's worth the risk to take the drug. At least try to take the drug, and if you can't tolerate it, okay, then we've at least given it a chance. But for the vast majority of people, these drugs are tolerated very well.
Let's talk a little bit about primary versus secondary prevention, because there is a difference, and maybe define the morbid events that we're trying to have less of.
Well, the morbid events that I talk about, and I try to define them carefully so that people aren't turned off by the phrase morbid event. Anything that forces you to be treated, recognizing that you have an underlying disease process like a heart attack or a stroke or heart failure, any event like that we call a morbid event. And those morbid events trigger the emphasis on secondary prevention. The moment an individual has chest pain caused by coronary disease, for instance, we say, well, that's a morbid event. Now we've got to treat this person because we know this person has disease, therefore it's secondary prevention. We would like to move the diagnosis of secondary prevention earlier by finding people who are not having symptoms but have the disease process that may subsequently lead to symptoms, and we call that early disease, and we then advocate for secondary prevention with the therapies that are already widely recommended for secondary prevention. So we're trying to move the ball earlier in the course of the disease, identify secondary prevention before it becomes symptomatic, and intervene with therapy at that earlier stage.
And primary prevention is primarily the responsibility of the primary care providers, but it's kind of a complicated thing to get right.
Well, primary prevention is the responsibility of the community. That's where our health agencies come in, efforts to alter the community's dietary and exercise practice to lose weight, to provide a smoke-free environment, to rail against smoking, which is a terrible burden to the cardiovascular system. So that's where the community efforts come in. The primary care provider should be giving individualized care, not focusing on the community effort to lose weight and avoid smoking, but to get individuals who have early disease identified and treated effectively.
We have a couple of minutes left. I wanted you to say a word about the final chapter, A Future Free of Symptomatic Cardiovascular Disease. Can we eliminate those events to age 100?
Well, I think we can eventually. Our goals are a little more modest to begin with. We say, well, let's at least aim to keep people healthy to age 90. I must say, as I get older, I keep wanting to move that target out further. But realistically, we need the whole effort in reducing healthcare costs requires us to delay disease until it occurs at an age in which we can comfortably say we don't provide expensive care for management. If you have a heart attack and you're 101 years old, I think the healthcare system should say, well, you're not eligible for all these advanced care efforts that are so expensive. And if we can ration care beyond the age of 100 and keep everyone free from heart attacks until age 100, then I think we've accomplished a great reduction of healthcare expenditure, which is the only way to go. We can't continue to increase the cost of healthcare by providing expensive devices and procedures to keep people functioning after they get very sick. And that's what we're doing now. We're providing sick care now, a very expensive sick care in this country. We do a better job of sick care than any other country in the world, and it's very expensive. What we need to do is provide health care at an earlier stage to keep people from getting sick and thus curtail health care costs.
Fantastic. That's a great finishing thought for this interview, and I appreciate it very much. We've been talking with Dr. J. Cohn. The book is Cardiovascular Health, How Conventional Wisdom is Failing Us. It's a good read. It's clearly written, and it's making me think, because I'm getting up there in years myself. I'm your host, Dr. John Cook. If you don't hear our regularly scheduled broadcast with these book interviews, you can always go to YouTube. The channel is Good Books Radio, Strong and Cook. Thanks for listening.